Everybody have a nice 3-day weekend? It's good weather. Who earns a living driving people away? A chauffeur. There you go. It's a taxi driver, where the chauffeur works. A little bit more sophisticated than a taxi driver. Okay, I'll go with chauffeur. What do you get when you cross an elephant with a fish? Spelled elefante, by the way. There's an E at the end of elephant. What do you get when you cross an elefante with a fish? Swimming trunks. All right. I actually like this. What's the difference between a jeweler and a cell biologist? A jeweler and a cell biologist. A lot. It's different. Okay. One sells watches, and the other one watches cells. Very good. Boom. Okay. So, we're kind of in an awkward phase of the semester because we have all this time off. And so we're trying to squeeze in lectures around your vacation schedule, okay? So we had Monday off, and we will have lecture today, and then we have lecture next week, and then we have lecture on Monday, and then we take a Wednesday off before Thanksgiving. You guys remember that? So some of you have flights maybe on Wednesday, you get better prices, get out a little early if you want, okay? And then we come back from Thanksgiving week, and there is an assignment due Black Friday. You guys look at your schedule, okay? So if you're going to be standing in line all throughout the night, maybe take an iPad with you so you can do your quiz before midnight on Friday, okay? Or buy an iPad, some Black Friday deal, and then log in and do your quiz, okay? Fine. Either way, just don't forget. Then we've got cardiovascular, so we've got liver, respiratory, and then cardiovascular, and we're done. Or we got to take it final. But we're kind of on the downward slope. Average on the exam was 79, so it was up, 4 points from exam 1. Gosh, I can't imagine an average being in the 80s, but it's possible. Usually exam 3 is even a little bit higher than exam 1, so maybe the average would be 80 or 81. You guys are just getting smarter as the semester goes on. Okay. Or I'm more of a pushover, I'm not sure which one it is, but I think the difficulty is the same. Content, I think, is a little bit easier because you have a base foundation. We're gonna talk about inflammation today. Again, you're like, oh great. Yeah, but it's gonna come in the form of like liver disease. So it's kind of a cool new way to look at inflammation. Liver disease. Yeah, and then format on the last exam we talked about. I still have a couple of potential institutional makeups on the exam, so I'll get you your Scantrons on Monday. I know I had appointments with some of you this afternoon after class, that's fine, keep them. Any comments or questions before we dive into liver? All right. So, which of these is not a function of the liver? Protein manufacturing, lipid storage, detoxification, glycogen storage, biomanufacturing, or all but B, or all of the above? All of the above. It's kind of an obvious question, but the whole point here is to highlight how important the liver is for our bodies. You can't live without it. So when it becomes diseased, we've got an issue. Now, this slide has one updated bullet point, because as I was reviewing my slides, I realized I left off a fairly important word because we're going to go talk about it here in the remainder of today towards the end. And that's hepatitis. So the last bullet point is not on your sheet, which you can easily add in. So let's talk about some of these review terms, and then we're going to focus in on hepatitis. And we're going to focus more on the alcoholic variation of hepatitis. And I'll explain more of that in detail. But all underlying hepatitis has similar pathological states. It's an inflammatory disease. Right? So hepatitis itself is an inflammation of the liver. Many of you are familiar with the viruses that tend to attack liver tissue. Right? So you can get vaccinated for many of these. So the viruses like A, B, and C, Hep A, Hep B, and Hep C. So these are viruses that attack the liver tissue and cause inflammation of the liver, and then ultimately necrosis. And we'll talk about that. But you can have hepatitis manifestations that are non-viral. You can have it because of toxicity to the liver, through poisons or medications or alcohol, which is basically a poison. And we'll talk about that. But let's back up a bit and let's talk about bilirubin. So who can explain to us what bilirubin is? Any takers? Bilirubin? Okay, so it's heme catabolism. So the heme component within the red blood cell. So it's correct to say it's red blood cell breakdown. Be a little bit more specific to say that it's heme catabolism. And heme is a component of the hemoglobin molecule, which is the principal component of red blood cells. And so it's a yellowish breakdown product, bilirubin. And if you don't break down bilirubin enough, right, as you recycle your red blood cells, they have a lifespan, and they have to be recycled. And as they break down, you get this bilirubin byproduct, and you excrete it typically. And the liver helps with this process of breaking it down or neutralizing it. Well, if the liver's not online, and you get too much bilirubin in the blood, known as hyperbilirubinemia, right? Hyperbilirubinemia, then you become jaundice, and that's that second term. So jaundice is a yellowish coloration of the skin or the white of the eyes, and because you've got unconjugated bilirubin, and it usually binds in the bloodstream with albumin. And if it's unconjugated albumin, then it's floating around and you're getting this yellowish color. So, interesting fact, there is a population of infants that are born with jaundice. And a lot of times that's because the liver isn't fully operational. It hasn't come online. Yeah, because the mother and the fetus share a blood supply, most of the detoxification of the blood can be done by mom. And so it's not necessary for the fetus to have a fully functioning liver until after it's born. And so if there's a little bit of a delay in that process of when it comes online, then that infant postnatally can develop jaundice. And there are light therapies. So many of you are familiar with this light therapy for jaundice babies, where you can, it's almost like the baby's sunbathing. You put this light therapy over their crib, and this specific wavelength of light, I don't remember what it is off the top of my head, if you can look it up, and this wavelength of light actually helps facilitate the breakdown of heat. Now, there's another population of patients that wrestle with jaundice, and the reason light therapy is successful for infants is because it's temporary. Right? The liver's coming online. The second population of patients that wrestle with jaundice are patients that are chronic alcoholics and they have cirrhotic livers. And so the liver has become basically compromised. It's not working anymore. And so you're not going to ever get it back online. You're going to have to go on a transplant list. Okay? So jaundice, yellowish coloration due to this high bilirubin levels. Cholestasis. Cholestasis is biliary pigment that's found in the canaliculi and hepatocytes because you've got decreased bile flow. So the gallbladder stores the bile, but what makes the bile? What? Liver. Okay. So if the liver is manufacturing the bile, then it's to be flowing to the gallbladder, but it actually gets restricted because of disease. Then you can have this cholestasis where you've got a decrease in bile flow out to the gallbladder. All right, and ultimately to the duodenum where it actually empties. Portal hypertension. So portal hypertension is a big problem. Portal hypertension is occurring when you've got high blood pressure in the portal vein. And if you got high pressure in the portal vein, then the liver itself is under a high pressure system. And now this high pressure is compromising liver functionality because it's not used to seeing this high pressure. So portal hypertension, or the portal vein, disrupts flow throughout the liver, and therefore it disrupts liver functionality. Coagulopathy. So every coagulation factor except for factor VIII is manufactured by the liver. So if you have liver disease, the patient could be in a coagulopathy situation where coagulation factors or proteins on that coagulation cascade, 1 to 1A, 2 to 2A, so on and so forth, except for VIII, factor VIII. All of those coagulation factors aren't going to be made at levels that are appropriate. So you'll have clotting issues. You may have excessive bruising in these patients because of this coagulopathy, where they're not able to clot the blood if they have trauma to the vasculature. Hypoalbuminemia. So this is different than bilirubinemia. This is albuminemia. So albumin is manufactured by the liver. We talked about albumin. And albumin is a very large molecule that never leaves the vasculature. Bless you. So even when you have massive vasodilation and you've got a leaky vascular bed and you get transudates and exudates that are leaking out in an inflammatory situation, it never gets to a gap large enough between endothelial cells where albumin can get out under normal conditions. Okay? And the reason for it, what's the reason for that? Why would you not want albumin to leave the vasculature? It maintains blood colloid osmotic pressure. So that's the pressure head that says if you've got high concentration of protein inside the vasculature, then water follows solutes, and you're going to get reabsorption through osmotic pressure, right? Colloid osmotic pressure. That osmolarity gradient is going to encourage fluid to reabsorb into the venous circulation. So if you don't have that, if you're hypoalbuminemic, meaning the liver isn't making enough albumin, what do you think is going on physiologically? What's that? Edema, tissue edema. That makes sense? A lot of fluid is leaving, and you don't have a pressure gradient through albumin to encourage it to come back, so it stays out into the tissues. We'll talk about this a little bit more as we move on. And then the last one is hepatitis. We kind of talked about this is an inflammatory disease, and we're gonna touch on alcoholic hepatitis later. But I wanted to put it up here. It's not on your slide. I added it today because as I was looking at the lecture, I'm thinking I'm always making adjustments. I mean, I've been doing this for over 10 years, and I still review my lecture deck, okay? Because I want to make sure that there's new information or if I missed something. And so I thought it was more appropriate to kind of introduce this hepatocyte or hepatocytic inflammatory disorder right up front. Because in all of these situations that you have that we've talked about, the liver itself is going to be in a state of inflammation. Right? It could be a virus that causes that. We talked about hepatitis A, B, and C. But it could be toxins as well. And we'll talk more about that. Which organs connect liver, to the liver via veins. Which organs connect to the liver via veins? So small intestine, stomach, esophagus, spleen, everything but C or all of the above. All of the above. So this side of the vasculature is really perfused mostly by the venous circulation. So we talked last week, Wednesday, about the kidneys. Remember, about a third of all blood flow comes off the aorta and it perfuses the kidneys. Well, here on the liver, okay, also in the abdominal cavity, the liver is actually interacting with all of these tissues via the venous circulation, not the arterial circulation, which is kind of interesting. So that's why the portal vein, or the venous side of the blood flow with hypertension, is a problem. Now, we're going to look in a couple of weeks, so I'm going to give you like a foreshadowing statement. In a couple of weeks, we're going to look at cardiovascular issues. And everyone loves to focus on the systolic side, or the left side of the heart. That's the working, we call it the working side of the heart. Like the right side of the heart is lazy and it doesn't do anything. Okay? So the left side of the heart, or the working side of the heart, that's where the problems are. That's where most of our myocardial infarction problems are, heart attacks. That's where we're concerned about hypertension, stenotic disease of the valves. Well, if you're on the right side of the heart, right, the non-working side, in air quotes, the non-working side of the heart, and you get problems on the right side of the heart and it backs up, you get a lot of issues associated with the liver, okay, because of the backup on the venous circulation. You guys with me? So, don't forget about the venous circulation, and don't forget about how the liver depends heavily on venous flow. So we've got this condition of portal hypertension, and we've got problems for portal hypertension, which could be due to right-sided heart failure. Right-sided heart failure. Okay, so we haven't talked about cardiac yet, but I know you guys have all had 202. Well, you're supposed to, that's a prerequisite. So you got my left, okay, which is facing your right, but my patient's left and patient's right. And the left side of the heart, the working side of the heart, empties out into the aorta, and the right side of the heart receives from inferior vena cava and superior vena cava venous return. And that venous return is coming from the venous circulation. So if you have a heart failure on the right side, you get pressure backup or hypertension that will ultimately affect the portal vein. So right-sided heart failure can cause this portal hypertension. What else could cause portal hypertension? Well, disease of the liver too. Okay. You've got vascular disease in the liver. You've got necrotic areas of the liver. You have scarring in the liver. And so now the liver is not as soft, it's harder than it was before. So if you imagine a blood vessel through a soft tissue, blood can flow nicely. Blood through a hardened tissue, it's compromised. Does that make sense? Okay. So this leads to liver dysfunction. There's a picture here of this portal circulation. So you can see how remind you of how all of these venous flows interact within the abdominal cavity. But this liver dysfunction leads to this condition of low albumin levels. And these low albumin levels, because albumin is made by the liver, causes this edema, like we talked about. So now you get this condition, what we refer to as ascites, A-S-C-I-T-E-S. It's not on this slide, you should write it down. Ascites, A-S-C-I-T-E-S, and you're going to see it here in a second, where you get a lot of accumulation of fluid in the peritoneal cavity because of this portal hypertension. And these ascites in the peritoneal cavity cause a lot of distension of the abdomen. And often the veins get distended, and that's what we call varices, V-A-R-I-C-E-S. So these varices, or these distended veins, due to this pressure imbalance that's taking place. And I want to remind you, if we've got a situation of hypotension, then we're going to release renin, right? Renin, if blood pressure is too low, you're going to release renin by the kidneys, and that's going to conserve water and raise blood pressure. So in this situation, when you're losing a lot of fluid, this is a deleterious positive feedback loop. Right? I can't say negative positive feedback loop, so I have to say another word other than negative. You guys follow? Deleterious, not good, positive feedback loop. So, liver's compromised, right? Fluid leaves. We've got portal hypertension, liver's compromised, low albumin. Fluid leaves. We've got the situation of accumulation of fluid, ascites in the peritoneal cavity. That's in the abdomen. And then we get these distended veins, these varices. And then we register low blood pressure, so we release renin. We conserve water to try to raise blood pressure. What does that do to the situation that we just started with? It makes it worse, right? So it's a positive feedback loop that's problematic. So I talked about this a little bit in the beginning. So these are ascites. This is, well, you've got both here. You've got ascites where you can see the distended veins with varices, and you can, the ascites is the accumulation of fluid in the peritoneal cavity with this distended belly. So this individual isn't like, kind of got like old man beer belly per se, right? Not necessarily overweight. The problem is he's suffering with liver disease. And one of the reasons, bless you, one of the reasons you know that is, if you have overweight individuals, usually when they're laying like this, things are going to distribute differently. Number one. Number two is the veins aren't distended, right? So we've got distended veins, which tells you there's a pressure problem. It's not just that they're overweight. And I mentioned this sort of situation earlier in the semester when we were chatting. I don't remember what the context of it was, but this individual on this slide is wrestling with, end-stage alcoholic liver disease. And we're going to talk about that towards the end of the lecture today. But there are similarities between this patient population and another patient population, which are found in these images of these little kids. And I went through a lot of schooling before I really understood this and put this together, because I remember being elementary aged, and you'd get relief organizations coming in and talking to the class. And I'm almost embarrassed to say this because I don't mean anything offensive by this at all. But I remember them showing us pictures of little kids like this. And this is in the 80s when Ethiopia was in this huge drought. Okay, there was this famine in Ethiopia. And there was even like Hollywood musicians that threw fundraisers for Ethiopia on this, and we would get some of these talks. And I remember looking at this going, and this is just how my brain, I didn't say it because I was a little shy, not anymore, but I was shy. And I remember thinking in my head, well, that's really weird that, bless you, that they would try to tell us that these kids are starving, but they look like they're fat. I know it sounds horrible that I just said that, right? But I remember thinking, well, they look like they're eating too much. I don't understand how they're trying to explain to us. But the person explaining it to us wasn't doing a great job of explaining the physiology. It's complicated physiology of why that distended belly of these starving kids is the same thing that's happening in this gentleman that's wrestling with alcoholism, but they're for two completely different reasons. So not necessarily really anything wrong with their liver, but because they're so malnourished, they don't have enough energy to manufacture enough albumin on their own. So their liver is just starved. So albumin production in these children, and let me see, Kwashiorkor syndrome is the name of this particular disease. I probably butchered the name. But in these kids, they're so starved and malnourished that their liver isn't manufacturing albumin, which is the same thing that's happening to this gentleman because he's poisoned his liver. And so they've got the same issues. They've got the ascites and the varices that are happening. And that distended belly. And I remember in high school hearing, oh yeah, the distended belly is indicative of starvation. I'm like, why? No teacher ever explained it to me as to why. They just said, it is. And I'm just kind of that person who's like, well, that doesn't make any sense. Like, there's got to be more to the story. So I'm telling you, that's the story. That's the reason. The reason I'm spending so much energy on this is it's somewhat related, but it's also culturally important because you all will be educators and you can go finish the story that other people try to tell, but because you have a little bit more knowledge, a lot more knowledge, than maybe that average individual that's telling that story, you could probably help young kids like me who are not believing what you're saying. Does that make sense? Okay. So, two completely different scenarios, very similar outcomes. In the liver is being compromised. One, the liver is being starved. The other one, the liver is being poisoned. Questions? Is that clear? Did anybody else actually wonder some of those things? Am I the only one? Okay. All right. So yeah. So that meant a lot of my classmates were like, "Yeah, I'm not giving you $1 either." Okay. I mean, I feel bad like admitting it, but it's like it wasn't a great explanation. So. Okay, so hopefully that helps. We're going to transition to alcoholic liver disease, and there's a reason that I select this. The statistics in this age group are somewhat staggering on alcohol abuse. Okay, and I'm not picking on you. The statistics on alcohol abuse, generally speaking, are staggering. Right? There was a time in this country when alcohol was prohibited. It actually didn't go well at all. I wasn't alive, but thank goodness, because I couldn't get a nice glass of wine. But, well, you could, but I think you were breaking lots of laws. So it's interesting to me socially. We're going to talk, when we get into the respiratory section next, after this, we'll talk about smoking. Because alcohol consumption and smoking, and now in certain states and under certain terms, marijuana, these are all legal activities. And many of you are very healthcare focused. And so I think we all will have an opinion about this. And your opinion is probably going to be really important because you're going to be some of the most knowledgeable people in the future, potentially making policies about what's going on here. Does that make sense? So, and this isn't a soapbox lecture by any, I'm not trying to make it be, but some things that are a little incongruent or a little interesting in our country. I'm not saying what's right or what's wrong. So, drinking age, legal drinking age, I think in most states is 21. Okay. Legal smoking age in most states is 18. Now in many states, vaping, right, has been banned in certain teenage age groups. I don't have all those statistics, but I'm going to look at some new information before our respiratory lecture. Because there was a time I was teaching this class so early, long ago, that means I'm so old, it's a fun way of saying that I remember when vaping first, or they were called e-cigarettes. Now that's like, right, that's like calling it the World Wide Web, right? Are you using e-cigarettes? Like nobody says that, right? But I remember when they used to be called e-cigarettes, that was the first terminology. And so I have slides on e-cigarettes, and I'll pull out these old slides on e-cigarettes. And some of these articles that we had on e-cigarettes, and now it's kind of shifted over to vaping, that's the terminology. But I remember students asking like, so what do you think? What do you think, Dr. Kelly? Do you think this is good or bad? I said, well, I remember as a kid when regular cigarettes were not considered unhealthy. And doctors would smoke them inside the hospital, like in the waiting room. Patients would be smoking cigarettes in the waiting. Some of you were like, really? I'm like, yeah. Restaurants. And then they got smart and made smoking and non-smoking sections inside a restaurant. And they were the division of smoking and non-smoking was like a row of plants. Like that was like the magical division for air quality. It was unbelievable. And so now we got all these rules. You can't smoke within like 500 miles of the sign or whatever it says. I think it's like 50 feet, but So you guys are going to see a lot of data. You're going to see a lot of data. You're going to be making decisions with data that we don't even have today. And even since I've been teaching this class, new data has come out, and the FDA has made decisions about vaping. And many of you know that. I mean, mint is banned. You guys know that, right? The mint flavor. Like, what's so wrong with mint, right? Like, I have a mint essential oil, and that you can diffuse or whatever. Am I like a felon? But I think as long as I'm not inhaling it, I'm good. Right? Is that DJ's like, yeah, you're good. All right. So don't be smoking it. Okay, got it. Don't light it up and smoke it. But what's wrong with mint? It's because the FDA and the CDC have discovered that children, I should say teenagers, I don't like to call children, teenagers are really attracted to the mint flavor. And I can remember that like mint cigarettes were really popular when I was in high school. And so I mean, there's a reason that they make mint flavored cigarette. I mean, Cool was the KOOL was the brand. Some of you are like, really? Yeah, I remember this. I couldn't stand the menthol flavor, but some people just love it. Okay, so they banned mint. So are we going to be banning alcohol in this country? I'm not trying to say that we should. I mean, I do enjoy having a drink, so I wouldn't be for it. But there are a lot of people, I think, that can't make good decisions about alcohol consumption. So that's why I picked on this particular topic. And it does relate to alcohol liver disease. Okay? Does that make sense? We could have a whole lecture on hepatitis C, viruses, and sexually transmitted diseases associated with hepatitis. But I thought maybe we'll focus on drinking. How's that? Okay? However, when you talk about hepatitis as an inflammatory disease, a broad category, whether it's alcohol as the medium, that's the etiology, the trigger, or whether it's viral-induced inflammation, or whether it's a liver toxin, like acetaminophen poisoning. You guys with me? So here's another one. One of the most common drug overdoses amongst pediatric patients is what? Acetaminophen, otherwise brand name Tylenol, but the drug name is acetaminophen, okay? And it's well-meaning parents. And this is the same stuff that happens if people are drinking too much, if they contract a sexually transmitted disease of hepatitis as a virus, or if they're giving their kids too much Tylenol when they're battling a fever. And so this is why it's so important for us to understand what's going on with the liver with hepatitis. And I'm picking on alcohol, but it could be either one of these. So with acetaminophen poisoning, and we looked at a slide on acetaminophen poisoning earlier in the semester. So one of the intermediates of acetaminophen, NADPQ, I think is what it is a liver toxin. It causes necrosis of the liver. It kills the hepatocytes. And alcohol will do the same thing in large volumes chronically over time. Okay, so let's look at normal liver up top, steatotic liver on your left, and hepatitis liver on your right, and then a cirrhotic liver at the 6 o'clock position, or down low. And so this is a somewhat continuously moving pathology because the liver is actually a very resilient tissue. Hepatocytes have a crazy regenerative capacity. And early in my career, when I was looking at playing with cells in the lab, and I kind of stuck with fibroblasts, but we were playing with hepatocytes at one of my companies. And we were culturing hepatocytes, and one of the scientists was using hepatocytic cultures as maybe a drug screening tool for pharmaceutical companies. So the idea would be you grow in a plate human hepatocytes or liver cells, and then you spike it with different pharmaceutical agents to see what the lethal dose is, right? So you do have, it's a drug test to get FDA approval because you have to prove that it's safe. The alternative is you do animal studies, and you dose these mice with higher and higher levels of drug, and at some point they die, and that's your lethal dose, and then you back it up. Some of you are like, what? Yeah, all of the drugs on the market have to go through this. I'm sorry, folks. Like if you have a prescription medication ever in your life, there are animal studies that are done in order to get it approved. But there are now newer tests that are benchtop tests, like hepatocyte culture, where you don't have to necessarily do animal studies. I thought that was pretty cool. So I almost went on that project because I was really interested, but I stuck on skin. So normal liver, and the reason that it was so interesting to us is human fibroblasts or skin cells grow like really well in culture. Same with hepatocytes. Both are very regenerative. So a normal liver, you get an exposure and you go into a steatotic situation, and then the exposure goes away, like the poison goes away, and it'll go back to a normal situation. This is saying abstinence because we're talking about alcohol consumption. Same thing here. Hepatitis. You've got a severe exposure, it moves over into hepatitis. You refrain and it goes back into a normal state. You can move from steatosis to hepatitis, and of course you can move on continued exposure from either of those two situations of hepatitis or steatosis to cirrhotic liver disease, but you can see the arrows don't go backwards. And the reason for that is here you've got this key word. What does this word mean to you, fibrosis? Scarring. What does that mean from a wound healing standpoint? Loss of function, thank you. You guys see the ties? So this is like the same old story, just in a different tissue organ, which is what I promised you in the beginning of the semester, and I'm trying to make good on that promise because it's true. You're just going to be looking at some of the same pathology mechanisms in all these different tissues that you look at for the rest of your career, which that's why it's so foundational. It's kind of cool. That now, we've learned the basics of how to communicate, and now you guys are pretty well equipped to go study a new disease and say, okay, I understand what's going on because I understand a lot of these inflammatory pathways and how this could actually lead to that. All right, so we look at steatosis. That is considered to be kind of the first level of disease. And then hepatitis would be considered more severe, and then the most severe would be considered what? Cirrhosis, okay, the fibrotic liver. Even though these two are kind of on the same plane, this one is considered to be more aggressive. Steatosis, the beginning, we've got fatty change. The liver becomes fatty. And we'll look at some of this histology as we work through the slides. That means that you are favoring a lipogenesis situation versus lipolysis. You're not necessarily breaking down fat, you're actually storing fat in the liver, and the liver starts to become more fatty in content. You got perivenular or venular fibrosis. So around the profiles of the triad, you start to see a little element of fibrotic disease that's taking place, but it's not scarring at this point. So it is reversible. You move over into hepatitis. Now we start to see some liver cell necrosis. You start losing functional hepatocytes. We've got excessive inflammation. We've got fatty change that continues. And we've got these structures known as Mallory bodies that we'll talk about here in a second. And then last but not least, on cirrhosis or a fibrotic liver, we get these hyperplastic nodules, and you can kind of appreciate the artistic rendition of kind of the bumpy liver. And we'll look at histology here on each one of these situations. So let's talk about risk factors. Genetics is a huge risk factor. Huge risk factor. In all of these diseases, hopefully you can appreciate that the genes kind of rule the roost. It's the nature versus nurture argument, but it's not 50-50. More of what we've learned over time as we've gotten more sophisticated in our understanding is it may be more like 75 or 80% to 20%, the genes being the higher number. What the genes are coding for is hard to distract from. So the environment can play a role, but not nearly to the same extent that the genes play. Okay? And this leads to a lot of other sort of philosophical discussions as well, that many of you will probably have to make decisions about as you move forward in life. What I mean by that is genetic testing, right? So nowadays you can get your genes tested for all sorts of different diseases. And just to flash forward a little bit, when many of you decide to start a family and start having kids, there's genetic testing that can be done before you actually get pregnant to determine what the chances are of your offspring having certain types of diseases. Okay? It's just knowledge base at this point. But interesting that we're moving in that direction, right? And there's all sorts of questions of like, who gets that information? But what happens if it falls into the wrong hands? Like, well, who would that be? What about insurance companies? If they get a copy of your genetic profile and they realize that, golly, when you're 69 years of age, you're going to have a major heart attack. Well, you probably won't get life insurance, right? Or you'll get life insurance that expires at age 68. That's all they'll let you buy, right? So a lot of these kinds of things that you guys will be wrestling with. So genetics is a huge component. The environmental piece is on top of that. So risky use. What's risky use? Well, this is defined, okay, this is defined by the CDC as greater than 4 drinks per occasion on a regular basis. Greater than 4 drinks per occasion on a regular basis. What's a regular basis, right? Is that once a week or is that once a day? Okay? Some of you probably wouldn't argue with the one a day being, I have 4 drinks every day. That seems like a lot, but, okay? Who knows? I mean, there's a lot of open interpretation here. Low risk is considered when, you do have social activity, but there's no hangover. Okay? That means that physiologically, you haven't let it get to a point where the effects of the poison have exceeded the capacity of the liver to detoxify. I'll explain here in a second. Because that's all alcohol is. You're consuming a poison, and you consume it faster than the rate of detoxification, and that's when you feel the effects. Does that make sense? It's like nobody's like, oh, it's super fun to drink really slow. Like you never hear that like on bumper stickers, right? You don't read that in frat houses. It's funner if you drink slow. I mean, it doesn't resonate. So if you're consuming the alcohol faster than the rate of detoxification of the liver, then that's when you feel the effects. So if you have a hangover, that means you're outpacing your liver. So the etiology of liver disease, alcoholic liver disease, obviously is excessive alcohol consumption, and lots of people have opinions on what excess is, and that's why I'm giving you some guidelines, some parameters, just to make you aware. But the damages that are done are to the microtubules, the mitochondria, and the membrane fluidity. So if we look at the morphological differences between the 3 types of states, we've got cholestasis that shows up where bile cannot flow. That's that bile cannot flow. This is in steatosis. We get a large, soft, yellow, and what's considered a greasy liver because you get the beginnings of fatty change. You've got alcoholic hepatitis over on your far right. Here we've got hepatocyte swelling, so the early signs of inflammation. And then we get Mallory body formation. This is alcoholic hyaline formation. So this profile that you're seeing is this photo, the hematoxylinated stained picture in the middle or the left histology image is actually normal liver. So you can kind of see the pink architecture. If you look carefully, you can see purple nuclei. And then on the right is a hepatitis liver. So that lower right is the hepatitis liver. And what I'm trying to point out to you here are these Mallory bodies that are full of hyaline. So they almost look like they are wax-like droplets, where we've got sort of a swollen-like cell with hyaline cartilage inside that's highly eosinophilic compared to kind of normal architecture, and this is indicative of a hepatitis liver. So on biopsy, that's what this condition would look like with all of these Mallory bodies. Okay? Pretty obvious when you look at normal histology next to hepatitis liver. And then last but not least, we've got our cirrhotic liver. Again, non-reversible. We've got these micronodules that will form, and we'll talk about those and show those in a little bit more detail. And then we've got the liver itself appears in a shrunken state, and it's really non-fatty because the fat tissue has been replaced now with collagen fibrotic scar, and I'll show you some histology pictures of that here in just a second. So what's the pathogenesis of steatosis? So I told you that alcohol is a poison, right? So it's kind of interesting that we consume a poison to relax. I guess that makes sense. Or to have a good time or be socially engaged. And the faster the rate of poison consumption, meaning it outpaces the ability of the body to detoxify it, then the greater we feel the effects. So let's talk about this reaction. So this reaction here is showing that you've got alcohol, top left, alcohol plus NAD leads to acetaldehyde and NADH. And then that moves over to acetate. And alcohol dehydrogenase is what catalyzes the reaction from the left side to the right side. And the intermediate there, hang on, let me get to my notes here. Okay, so this intermediate of NADH has these effects on the liver tissue. We'll walk through this. Is it inhibits lipolysis, the breakdown of fat, and it encourages lipogenesis, which is the production of new fat. And so if you've got early phases of steatotic liver, what you're seeing is you see all these open vacuoles. So now you've got fatty liver disease. Here's a little bit of what appears to be scar formation. So this would be reversible except for this portion right here. All of this fatty liver could come back if the consumption was decreased, okay, or the poison that's driving this hepatitis, or sorry, this steatotic situation is removed. So the NADH intermediate is a liver toxin or a poison that's causing a lot of these fatty changes to occur. Now we've got a little statistic here, which population is alcohol abuse, okay? And it's probably defined in a number of different ways, but which of it is greatest, which age group? 15 to 17-year-olds, 18 to 29, 30 to 54, or 55 years and older. So it's this age group that happens to be college age, okay? So that's why we're talking about this. All right, so let's talk about alcoholic hepatitis. So we go back to this prior reaction here. So when I highlight this, we've got ETOH, which is alcohol, plus NADH plus leads to these two intermediates, acetaldehyde and NADH. We talked about NADH's effect as a liver toxin. Now let's talk about acetaldehyde. So acetaldehyde is also a hepatotoxin which kills hepatocytes and causes necrosis. And so if the insult continues, not only do you have fatty liver disease from the NADH's effects, but you develop necrosis of the liver, right? This would be a coagulative type of necrosis, and that's due to the acetaldehyde intermediate. So, back to my point. If you're consuming your ingredient at a rate where acetate can be produced, and you don't stay in this intermediate phase for very long, or at all, then you don't have these problems that show up. But that's not nearly as fun, okay? So that's not typically what's happening. So here's Mallory body picture, again, an alcoholic hepatitis. You guys see the swollen cells with the hyaline inside, that dark pink stain, like what we saw previously. So here's another picture of it, or histology to kind of remind us. So we've got an inflammatory event that's happening due to this necrosis. We get the appearance of white blood cells, right? So we're recruiting white blood cells out of the vasculature. So we get monocytes that come out into macrophages, right? And those are what are responsible for our inflammatory response. Tumor necrosis factor alpha, TNF alpha. These are actually, this is a growth factor, a cytokine. It's actually a cytokine that's manufactured from Kupffer cells. And I'm going to show you where these Kupffer cells are. But these Kupffer cells are basically a specialized liver macrophage. And they're shown in green on this picture. Okay? So we've got our Kupffer cell here that manufactures TNF alpha. Here's an activated Kupffer cell. This is normal liver. Here is a fibrotic liver. In this case, we're talking about alcoholic hepatitis. And then we've also got stellate cells. And these stellate cells, typically under normal conditions on the left, are quiescent, meaning they're in a resting state. Well, over here, in an activated state, they actually start manufacturing additional matrix or collagen because they're in a state of necrosis. So we've got inflammation. We've got specialized macrophages, these Kupffer cells. They manufacture this cytokine known as TNF alpha. Stands for tumor necrosis factor alpha. Now, what's confusing about biology sometimes is when one biologist discovers a molecule, they name it. And then oftentimes that molecule is discovered to be used in other places, okay, because biology tends to be efficient. And so the fact that it says tumor necrosis factor from a macrophage might be confusing. Because you might think, is that from a tumor? It has nothing to do with the tumor in this context. When it was first discovered, it was discovered out of a tumor mass. Because tumors actually manufacture TNF alpha. You with me? But I'm pausing because I don't want you to get confused. Because we talked about cancer, we talked about tumors, and I don't want you to get confused, like, why is this Kupffer cell making TNF alpha? Is it benign? Is it malignant? Nothing to do with cancer. It's just the same molecule that was discovered by another scientist in studying tumors, and he named it, or she named it, tumor necrosis factor alpha. Guess what? There's a tumor necrosis factor beta, because scientists aren't necessarily all that creative. Okay? Right? So, in the tumor, it can promote necrosis. That's why it's called tumor necrosis factor. Here, it stimulates additional inflammation, which causes more hepatocyte damage. Okay, does that make sense? Okay, so when you're studying, I just didn't want you to glance over that here, gloss over it, or be asleep and not hear it, and then you come back and you're like, I'm super confused. We're talking about cancer, or are we not? We're not. It was just discovered somewhere else, okay? These stellate cells, they become activated and they start contributing to fibrosis because they start making more extracellular matrix. And that's where you get this fibrotic scarring. All of this is reversible except for any scar. And we've been saying that since the beginning of class, the beginning of the semester. Okay, so we're winding things down for today. Get out of here a little early. Hopefully nobody will be upset about that. What about cirrhosis, our third state? Okay, non-reversible. If cirrhotic disease or fibrotic liver disease occurs because of hepatitis from a virus, or from acetaminophen poisoning, or from some other chemical compound, or from alcohol, if it gets to the state of significant fibrotic scarring, it is non-reversible. And these patients have to be transplanted. Okay? So the fibrosis is from repeat stellate cell stimulation. So we go back one slide. These cells that are normally quiet get activated. They make more matrix, scar, fibrosis, collagen. And if you do that over and over and over again, you get a lot of fibrotic scar that forms. the macrophage growth factors, not just the TNF-alpha, but all the other things that come out of these specialized Kupffer cells, or a liver macrophage, they start causing hypertrophy of the tissue, of the cells, hypertrophy of the cells. Overall, you might get a shrunken liver, but the individual cells will hypertrophy, okay? You get repeat cycles of alcohol damage and fibrosis, and now you have a compromised architecture, and that leads to portal hypertension, which is where we started the lecture, right? Because if you imagine a soft, spongy tissue with tubes running through it that have fluid flowing versus a stiff tissue that has tubes running through it with fluid flowing, it is much more difficult to push the fluid through the stiff tissue. Does that make sense? And so as this tissue stiffens up, it becomes scarred and lesioned and fibrotic, the architecture is compromised, and now pressure goes up. It takes more pressure to get the fluid through a stiff tissue. And so that's where you get your hypertension. Okay? And that causes compromised liver function. All right, so let's look at this slide. On the growth side and on the histology side. So this is a trichrome color, a pentachrome color. And in this particular pentachrome stain, all of the fibrotic lesions are lighting up pink. And so you can see all of these nodules of excessive extracellular matrix deposition in this liver tissue. And if you look at the surface, if you were to kind of rub your hand over this, we kind of saw a picture similar to this in the renal disease section. This would be bumpy, and this is the surface of this liver, how it's kind of this bumpy surface, which is what is being portrayed in this artist representation of a cirrhotic liver right here. Make sense? So again, kind of to summarize, we've got 3 disease states. I got one more slide that I need to talk about from a clinical standpoint. We've got the exposure of the insult, and usually you'll first go to a steatotic situation or steatosis, fatty change, some elements of fibrosis. You abstain, it goes back to normal. Comes back here. If it's more severe, it might move over to hepatitis. Now we start seeing necrosis, right? We see those intermediates of acetaldehyde, and we see the intermediates of NADH causing problems. We still have fatty liver. We get these Mallory bodies that you'd be able to identify histologically on an exam, for example. Right? Inflammation is continued. If either of these conditions persists, and the patient doesn't necessarily change their behaviors, then you're in a point of no return, and you're in a fibrotic liver or a cirrhotic situation where you've got fibrosis, we've got scarring, we have loss of function, and this is really, folks, it's not really any different than what we saw with skin. Okay? It's not any different than what we're going to see when we look at the heart, cardiovascular disease at the very end of the semester. All right, so let's talk about clinical manifestations. 3 different categories. Steatosis, we would have an enlarged liver here. Steatosis, we would have elevated bilirubin, which should make sense to us now that we understand what we're talking about. And let's move down to kind of the next category, second most severe, alcoholic hepatitis, malaise. That's a term, malaise, that means like just you feel crummy, okay? General discomfort. These patients display symptoms of anorexia, oftentimes because they're consuming more alcohol than they are food. So they're not really getting calories that are actually useful. They get a lot of weight loss. The liver itself is tender on palpation, even just pushing on it. Okay? Hyperbilirubinemia. So it's continuing to elevate. Now you're going to start seeing elements of jaundice or that yellowish skin color yellowish whites of the eyes. And then most severe alcoholic cirrhosis over on your far right, over here, we've got portal hypertension. Now we've got the whole liver is stiffer. We've got ascites with the patient, peripheral edema like we talked about. Malaise continues. There's weakness because, again, they're basically starving. Lots of weight loss, and the jaundice continues. And in the alcoholic cirrhosis category, as severe as it becomes, these patients typically get put on transplant lists, although, this is the moral thing or the ethical dilemma that maybe you may find yourself in. You've got a 15-year, let's you got a 17-year-old, let's call them minor, 17-year-old male, so probably fully grown, in a motorcycle accident, severed aorta, ruptured spleen, damaged liver, and fractured skull. Survives. On a transplant list for a couple of different organs, but mainly the liver. Okay? You can actually live without your spleen. Can't live without your liver. Or you've got, say, let's pick a number, 57-year-old male, pick on guys today, okay? 57-year-old male chronic alcoholic, and you've got one liver. And you're the transplant team. Where are you going to send the liver? Okay? So, if you're on this list here, you may not find yourself at the high end of the priority system. And this is just real world things. I've actually seen that happen. When I was working at Gore, we had a lot of 17-year-old male motorcycle accidents, believe it or not. That's because I was working on thoracic aortic aneurysms, and these patients didn't have an aneurysm, they had a transection. There's a ligament that holds the aorta kind of in place, and so when these individuals get in a motorcycle crash, it wasn't like they were doing 27 down the road, right? They're doing like 80 miles an hour, and then they crash and go to 0 miles an hour, and what ends up happening is that decellularization event, the aorta where the band is, the aorta kind of does this because the top of the heart's heavy, and so it does this, and that ligament kind of almost acts like a knife and it severs the aorta. And so they'd be borderline. Those that survived, they were lucky because it was a partial tear, and they would stabilize the patient, and then they would try to figure out, and I remember being part of this conversation where they're like, we don't know if we're going to get a liver for this kid, 17-year-old kid. I mean, legal to drive, to be on a motorcycle. 17-year-old kid, we don't know if we're going to get a liver because they're on a transplant list and there's a few people in front of them. And we probably weren't supposed to know this, but some of the people in front of them were in this category. And I was like, oh, man. I just make the devices. I'm glad I don't have to decide who gets what, you know. So this is real world stuff, but it's, you know, kind of weaving it into the lecture today. That's all I have for you. So we'll call it early. Hope you guys have a nice weekend. I'll see you on Monday. We'll start with respiratory.